keratitis. And I just want to share with you our experience at that particular time in 2020. And this is the first patient, a 54-year-old lady. She's a trader. She lives at Surulere. And on 6th day of January 2020, she presented to us with a visual acuity of counting fingers in the right eye, which is the affected eye, and 618 in the left, which is the normal eye. Our presenting complaint was that of pain, redness, and loss of vision in the right eye of 4 days duration. What actually happened that on the 2nd day of January 2020, after saying Happy New Year, at about 1 a.m., she felt as if there was something inside her eye. She developed foreign body sensations and some itching, some redness. Initially, she applied antibiotic eye drops, ciprofloxacin. She didn't get so much better. Then she decided to consult with people who advised her to put urine and sugar water in the eye, which she did on the 5th of January 2020. The following day, on Monday, she presented to us with some discharges in the eye, swelling, aperemia, and with cornea abscess. Because of the small pupil and the abscess obstruction, we couldn't see the posterior segment of the eye. Immediately, we took a conjunctival swab and they sent it for investigation, and this yielded Pseudomonas aeruginosa, sensitive to some antibiotics like ceftazidime, meropenem, gentamicin, and ciprofloxacin. That was exactly the report we got, yielding Pseudomonas aeruginosa. Left eye was essentially normal, and then we started managing this patient, and this was done for 4 months. 6th January, this is what we saw, and then we started on management with fortified gentamicin eye drops, moxifloxacin. We dilated the eye with atropine eye drops. We also gave Iflomax to promote healing, and tobramycin ointment, while we gave subpercordial injection of some antibiotics, including gentamicin, ceftazidime, and vancomycin daily for 3 days. She was also on parenteral ceftazidime 1 gram daily for 5 days. And after the parenteral injections, she had oral ciprofloxacin given to her for 2 weeks. Vitamin C tablets was given to her, nepafema, and then also cell wet drops, as well as cataclone tablets for pain in the eyes. We continued to manage her, and she had the cornea infiltration, the abscess, had some edema, some due to the injection we gave. And 8th of January, there was still a lot of inflammatory reaction. The eyelid was swollen. By the 8th of January, 4 days after presentation, she developed a hairline hypopyon, and then later she got a bit better. By the 13th of January, the hypopyon had resolved. There was progressive resolution. We were already trying to rejoice, but what happened was that by 7th of February, about 2 months, a month after presentation, we did a cornea amniotic membrane graft to promote the wound to heal very well, because we felt that healing was slow. Later, we also applied banded contact lenses. And then by 7th of March, we thought that we were doing well, and this was removed. However, we were shocked by 9th of March 2020, the hypopyon reappeared in the anterior chamber, and then we started the vigorous treatment that we have started before. And then again, by 10th of April, she had a foamy discharge in the eye. We took another swab, which now grew another organism, and coagulase negative Staphylococcus aureus, sensitive to vancomycin, Fusariasis in lesinocin. We started her with subconjunctival injection, parenteral injection. That was the result that we got from the second swab that we took. And by 20th of April, 4 months after treatment, the HOSA had now healed, leaving a scar, but there was reduction of vision to 636 and with PO 618. It's significant to know that 10 years earlier, this patient was came to our facility 10 years earlier. She had bilateral corneal ulcers from the use of contact lenses, which we treated, and she got very well. So we're shocked that she actually applied urine at this particular time. The last time we saw her was 8th of February 2021. At that time, there is resolution of the microbial keratitis, but there's a sequelae of a corneal leucoma. And we could see that when we did a cornea pachymetry and epithelium map, it showed there was a reduction in the thickness of the cornea, and then it also shows that the epithelium, there was also reduction in the epithelium map layer, showing that this had caused irregular astigmatism and distortion of the cornea as a result of the injury. Ultrasound B scan was essentially normal. The second case was a trader who presented in October, 10 months after, exactly on the 6th of October. And she was well until 3rd of October 2020. He had itching, he had watering, redness in the eye. And the following Sunday, he applied his own urine to the eye. Subsequently, he now developed pain, redness, photophobia. She also had foreign body sensation. He had also used gentamicin eye drops as well as ampiclox capsules and paracetamol tablets orally. However, by the time he presented to us, this was what we saw. A cornea abscess with hypopion. We took conjunctival swab for microscopy, and it actually grew coagulase negative bacteria at that particular time. And we also started management like in the first case with fortified gentamicin eye drops early, moxifloxacin, dilating drops, iflomax, topramycin ointment, and some bulk injections, as well as parenteral antibiotics. We gave also anti-allergic medication at this time, zinc chlorolopatadine, as well as Selwet, and vitamin C tablets. By the 15th of October, the result of the swab came out to be coagulase negative staphylococcus, which was sensitive to vancomycin, moxifloxacin, ciprofloxacin, and chlorphenicol. By that time, there was less inflammatory reaction. This was the staining. There was no ulcer. Pupil was dilated. The result of the laboratory investigation is as shown from Cleaner Lancet, a world-renowned laboratory. And what we now found out was that whereas by 26th of October, the vision had improved to 624 with pinhole, and we were almost about shouting hallelujah. But 5 days later, on 31st of October, the vision deteriorated again to 636. There was formation of hypopion the second time. And then we also now have to start the vigorous treatment with subconjunctival and parenteral injections again. And then we continue to treat the patient. Then this was the second hypopion that occurred by the 31st of October. We started treating, and then it got resolved. And this is the situation, what we see by the 5th of November. And then we now found out that there was dexamethasone, and by 5th November, there was actually perforation of the cornea. We had to use banded contact lenses, conformal prosthesis, and then we started to do conservative management as well. And what happened was this. SADA test we carried out was positive on 13th of November. But 3 days later, the perforation was sealed. And we continued to follow the patient up. And by 4th of December 2020, that was the last time we saw him, the vision had improved to 618 and with pinhole to 612. So we look at the cornea anatomy to see that in this case, we have the epithelium as well as the stroma being in.
Your 7 minutes is up. Can you round up, please?
Yes, the round up, the conclusion here, or the highlight is that number one, some laboratory tests that should be done, we were able to do a lot of them, but there is a limitation of poor resource setting. We would have loved a situation where once you can plate this in blood and chocolate agar and do other things, which I'm sure will be discussed. But the complications we saw was that of the coma. The patients can benefit from phototherapeutic keratectomy as well as penetrating keratoplasty. Right now, the regular astigmatism is being corrected with glasses. Both patients are traders. Both patients live in an urban area of Lagos, Nigeria, and it was shocking that whereas they lived in the urban area, yet they were, after some kind of frustration, able to get wrong advice to put urine in their eyes as well as sugar, which now worsened what was essentially a case of allergic conjunctivitis causing reduction in vision. This tells us that as ophthalmologists, we need to improve our eye health care information in terms of information, communication, and education, so that the society can know that a lot of these conditions, you don't need to, when you put harmful traditional medications and other things, it will actually make the matters worse. I thank you for the opportunity.
Thank you very much, Dr. Shoba. That was beautiful. Thank you very much. Dr. Ekpe, can you please unshare your screen, Dr. Shoba?
Yes, I will do that now.
Dr. Ekpe has sent his presentation to me. I will project it and he will speak to his presentation. Okay? Dr. Ekpe, over to you.
Okay. Good afternoon, my teachers and colleagues.
Please, 7 minutes. 7 minutes, please.
I present a pattern of presentation and microbial isolates of cornea.
Sorry, just an announcement. If you are not presenting, can you please unmute? I mean, mute yourself. Mute yourself if you are not presenting, please. Okay, go ahead, sir.
Sorry, if Dr. Ekpe has his phone on Zoom at the same time with the system, it's going to be giving us that type of sound.
Dr. Ekpe. Dr. Ekpe, use one device to talk to us and unmute with that device.
I'm on now, sir.
Go ahead, please.
Can you hear me, sir?
Go ahead. Go ahead.
Okay. I said I present a pattern of presentation and the clinical and microbial isolates of corneal ulcers at Alessekweme University Hospital at Abakaliki. This is a project that was funded by TED Fund. Next slide, please. Corneal ulcerations are commonly caused by corneal infections, which often lead to vision loss. The causative organisms differ significantly across regions. Hence, accurate understanding of the prevalent causative organisms, predisposing factors, and factors affecting severity and outcome is required to guide management, especially in poor resource economies like Nigeria. Hence, we set out to carry this research in order to, next slide, to determine the magnitude of corneal ulcers. Back, please. Previous slide. Previous slide, sir. To determine the magnitude of corneal ulcers presented at the Alessekweme University Hospital at Abakaliki, and also to determine the clinical pattern of the corneal ulcers, with a view also to determining the predisposing factors of the corneal ulcers, as well as the common microbes that cause the ulcers in our catchment area. This will enable us to developing an evidence-based management protocol. Next slide. It was a longitudinal descriptive study of all consenting consecutive corneal ulcers that presented in the hospital between December 2018 to December 2019. A detailed clinical evaluation of the corneal ulcers were made, taking note of the size, the depth, the clinical features, and the location of the ulcers. Cornea scraping samples were done for laboratory analysis. We commenced broad-spectrum topical antibiotics and topical antifungal medications pending results of the culture and sensitivity to guide a change of treatments. Relevant data were documented and analyzed using Statistical Package for Social Sciences, SPSS version 22. Laboratory procedure. Smears of the scrapings were done and placed on 4 slides for staining and microscopy. KOH mounts, gram staining, Jameson stain and modified field staining were done respectively. For the scrapings, we used the sterile backpacker blade size 15. Specimens were collected from the leading edges of the ulcer as well as the base of the ulcers. They were inoculated on blood agar, chocolate agar, and Sabron dextrose agar. The KOH mounts were examined under ×40 magnification. Gram staining and Jameson staining were also done. For the culture, it was all incubated aerobically at 37 degrees for 72 hours. And positive cultures were considered if there was a growth on both the blood and chocolate agar. We commenced empirical treatment with broad-spectrum antibacterial and antifungal agents. We used Keratitis, reconsidered as eye drops, 50 mg per ml, 50 mg per ml, and antifungal agents, natamycin and flucamide. For the suspected case of acantha amoeba, we use 0.02% chlorhexidine. Other supportive treatments that were used included 1% atropine eye drops and analgesics. These were done pending the laboratory results of the culture and sensitivity to guide our any changes. Next slide, please. Our results. 18 corneal ulcers out of 3,853 consecutive patients, which gave a hospital-based prevalence rate of 0.47%. The age of the patients ranged between 23 to 84 years, with a mean age of 50.4 plus or minus 15.7 years. There was a preponderance of females than males, with females having 61.1% as against males of 38.9%. Half of the patients were farmers aged above 45 years and mostly females. There was a preponderance of recent history of corneal injury prior to the onset of the trauma. More than 94% of the patients had 1 or 2 other medications before presentation. And also, majority of the patients presented 2 weeks or more after the onset of symptoms. The ulcers were severe in nature and mostly central, with about 78% of them being deep stroma. Next slide, please. This table shows the clinical characteristics of the affected eyes. More than 60% of the patients had a visual acuity of between 360 and light perception. Next slide, please. Next. Our laboratory findings. Microorganisms were isolated in 11 specimens, of which 6 were bacteria and 4 were fungi and 1 acantha amoeba. Incidentally, of the 6 bacteria that were isolated based on microscopy, only 2 yielded growth on culture, while 14 could not yield any growth. So most of the diagnoses were based mainly on microscopy, which gave gram-positive cocci in 5 patients and mixed gram-positive cocci and gram-negative bacilli in 1 patient. 2 of the 6 specimens diagnosed with gram staining showed growth on culture. One was Staphylococcus aureus and the other was Pseudomonas aeruginosa. There was no fungal growth in culture despite fungal hyphae and yeast that we are seen on 4 specimens respectively. However, there was no history of contactless use in any of the patients. In our outcome of our treatment, the outcome of the treatment was poor, as recorded with the visual acuity of less than 360 to light perception. But there was no need for evisceration. Next slide, please. The clinical severity of the ulcers on presentation correlates with the poor visual outcome. This is similar to findings in other studies in Nigeria and Africa. In a retrospective review of all admissions for microbial keratitis in Tanzania, East Africa, Burton et al. Reported similar severe ulcers of greater than 5 millimeters in 41% of patients with eventual poor visual outcome. Late presentation to hospital with poor facilities for adequate treatment was also observed. This pattern of presentation results in severe sight-threatening corneal scarring despite appropriate treatment. Such deep ulcers require penetrating keratoplasty. Hence, the need for corneal transplant services cannot be overemphasized in Nigeria. Next slide, please. In conclusion, corneal ulcers presenting at Federal University Hospital Abakaliki are severely sight-threatening. The microbial arsonists were predominantly bacteria, fungi, and occasionally acantha amoeba. Public education on early visit to hospital following eye injury is necessary. Hospital management and policymakers are advised to invest in corneal transplant services to enhance chances of vision restoration from resultant corneal blindness. Next. Thank you.
Thank you very much, Dr. Ekpe. I think I will be going to my own presentation, which should be coming up any minute from now, and is going to be looking at the pattern of practice in Nigeria. I don't know if you are seeing me. So can I share my slide now? Okay. So we're going to be looking at the pattern of practice in Nigeria, microbial keratitis in Nigeria, the current practice. Let me just start by saying that microbial keratitis is inflammation of the cornea caused by a microbial agent. Generally, it should be bacterial, fungal, viral, and parasitic. The viral is usually treated as a separate entity, while the rest are seen as called microbial keratitis. Then the diagnosis of viruses or viral keratitis now are not usually in the routine microbiological laboratory, where most of the time is at the molecular level now. So for the purpose of this webinar, we shall limit to just bacterial and fungal corneal infections. So what's the present practice in Nigeria? The teaching that we were all subjected to advises that when you suspect microbial keratitis, you should examine the patient after the regular history and the rest of it, because your history is so important. Our patients, there are some of things that are common with most of our patients. They present late. Not only that, they would have tried all sort of eye drops, bought from the chemist, usually not recommended by a professional. And sometimes they apply traditional eye medications. And as presented in the two cases by Dr. Shoba, these people, one used sugar water and the other used urine. So this is important for you to take a good and accurate history. Then when you examine, you should have a cornea diagram with color coding done. Then you should make a clinical diagnosis based on your slit lamp examination. After which you can now take cornea scraping for microscopic culture and sensitivity. Then you should start treatment immediately based on clinical finding using empirical information, that is from previous studies, from what you know. What if you think it's a gram negative, what are the things you should use? If you think it's gram positive, what are the things you should use? So you start treatment with that. Then you will modify your treatment when the laboratory reports come, and you have the culture reports. So if your cornea scraping for microscopy and sensitivity is not delayed unnecessarily, you should be able to get a report of the microscopy in the clinic. So right from the clinic, you are sure. Can you unmute, please? So if you receive the microscopy report, you are sure whether your patient is having gram-negative bacilli or gram-positive cocci or whatever organism that may be responsible, then you treat accordingly. Then you wait for another 24, 48 hours to get the result of your culture, if need be, and microscope and sensitivity. If need be, then you may have to modify your treatment based on the report. So now, before, when I was told that, look, we'd like to know how you practice in Nigeria, I sent out a questionnaire for a survey. We had, in that questionnaire, we had 149 respondents, of which 50 were consultants and 96 were residents. The practices are such that 70% of them are in the tertiary government institutions. And that shows how skilled our practice pattern is in Nigeria. Then another almost 11% are in the secondary government institutions, while 19% or almost 20% are in private or mission-based practice. So when looking at the area of interest of all the respondents, it cuts across all practices, that is, all specialties, with the general ophthalmologist having the highest number, and of course, cornea and anterior segment as expected, and also other specialties can be seen here responding. So as it is now, we do not have very sophisticated specialty practice in Nigeria, and most of us still have to practice as general ophthalmologists, even when we are having a specialty practice. We will evolve to the level that will just remain at our different specialties by the time we have more than enough personnel to go around. So then the location is also influences the practice. You know, I've talked about this. Most of them are located in the state capital, others are in the urban, and some are in the semi-urban, but most are in the state capitals, with almost 90 of the respondents practicing in state capitals. And of course, that means a lot to the management pattern. The laboratory services, we look at the type of laboratory services and the access to the laboratory services. 86% of the laboratories are located within the facilities of the hospital. And it's only about almost 12% that are being outsourced. 2.1% of the respondents do not use any laboratory services. Then when asked what percentage of the suspected microbial keratitis are subjected to microbiological laboratory investigations, in those who subject, out of the total they have, those who subject less than 10% of their patients were the majority. In other words, those who don't do or only sparingly do were in the majority, accounting for 67%. And also we have 67, of the 149 respondents. Then we have those who maybe about a quarter or less are subjected. There were 22 respondents, and those who subject more than 50% of the time subject their patients to laboratory investigation, 36. Well, this is not too bad, but it could be better. And that's the reason why we are doing this workshop, so that we can sensitize each other to it. Then how often do you get a reliable result? 69 respondents believe that in 10%, they get less than 10% reliable results. And of course, 25 people believe that over 50% of the time they get good reports, and the others are in between. So not too bad though. Then when asked how they are guided by the laboratory reports, those who just manage and without laboratory reports form the majority. That is, those who use the laboratory report in less than 10% of the times. We have 58. Then about 26% say they use it more than half of the times. And in between, we have these figures. So I think we are getting the pattern gradually of how we handle our cases. Then now there's a problem here, and that is of polypharmacy. A lot of people will combine antibiotics of different types with antifungal, and without any scientific basis that, maybe there was mixed infection. So those who use combined antifungal and antibiotics, over 50% of the times were 80. And those who use it, between a quarter of the times and half of the time, 48. And those who use it religiously, those who don't use it, that is, who separate this, are just 3. They are just 3. So that gives us an idea of what I usually call a machine gun approach to the management of microbial keratitis. So most of us, we just hit the cornea with so many drugs, thinking that somewhere along the line, one of them will hit it. I call it machine gun approach. Now, when we ask of how often do they come to a slit lamp diagnosis of, oh, this is likely to be fungal, or this is likely to be gram-positive or gram-negative microbial keratitis, only 37% are confident to classify microbial keratitis as bacterial or fungal. A slightly larger percentage are making some clinical classifications in 20 to 50% of the time. So about 40% of our respondents, then when asked about, making diagrams, clinical diagrams to represent the findings of the ulcer, about 40% of the respondents do not sketch their microbial keratitis findings, while the slightly less do so. Then about 20% sparingly sketch their findings for documentation. That is, more or less 20% don't do, don't do much, but some in between the sketch. Then when it comes to imaging, that is either digital camera or using smartphone, or the anterior segment imaging using the slit lamp, about 70% do not do any form of imaging on their microbial keratitis patients. So now when we were asking about what constituted the challenges to the practice, we found out that slit lamp differentiation was a problem for about 28 respondents, and imaging problem for 46, poor uptake of available good laboratory services. So even in areas where there are good laboratory services, about 56 of our respondents were not making use of the laboratory. We hope that at the end of this, we will wake up and be using what is available to us. Then about 38% were having, about 37 people, almost 26% were having issues getting appropriate antibiotics and antifungals. So the challenges to the clinicians, as put here, is that most patients cannot afford the cost of treatment and investigation. 63% of the patients, of the respondents, believe this. Then poor and unreliable laboratory facilities, poor uptake of available laboratory facilities, challenges with making slit lamp diagnosis of the microbial keratitis type, availability of appropriate microbial antimicrobial was a problem in 38%. Then issues with clinical drawing of corneal lesion was also a problem. Most patients present late, over 2 weeks, in 70% of our cases. So that was the response from the clinicians. Now we sent another set of questionnaires to the laboratory people, and we had 26 respondents. Medical microbiologists were 48, laboratory scientists 52, and no residents responded. That is resident medical microbiologists. So what were the findings that we had? When asked how often they were consulted before a corneal scraping, 14 of the 26 said they were never consulted before arrangements were being made for scraping. And about one person says, well, in 3 to 4 or 5 cases, they were being requested to be part of the investigation. This must be somebody that is very interested, and the practitioner as well as the laboratory personnel. Then others are in between. When asked how often they go to the clinic to assist in the collection, 15 of the 26 say never have they've never been to the clinic to assist in taking the specimen and transporting it to the laboratory. And 4 people say in 1 or 2 cases, in 1 or 2 or 5 cases, and 3 people say in all cases they were being involved. Then somebody says in 3 to 4 cases, 3 people responded that in 3 to 4 cases they were in the clinic to assist. So how regularly do they have a form of interaction like seminars, clinical teaching, or presentation with the ophthalmologist or the Department of Ophthalmology? Quite a large number of them said there was no interaction of any form in terms of knowledge share or improving knowledge with the ophthalmologist or the Department of Ophthalmology. And about 9 says once in a year is when they meet with the ophthalmologist. And somebody says about once in 3 months, and another one says once in 6 months. We can see that this is not good enough if we are really going to enhance our practices and make our patients to benefit from our good services. So what do they see as way out of improving the laboratory services? So most respondents believe that they need more interaction between the laboratory personnel and the ophthalmologist. They like to join seminars like clinical microbiological correlation meetings. Introduction of molecular diagnostic tools is being advocated. Awareness of the cause of microbial keratitis and adequate equipment and reagents to the microbiology laboratories is needed. Then there is a need for harmony within the laboratory personnel, medical microbiologists and laboratory scientists. In some institutions, some of these people can work together. In some institutions, they have harmonious relationships. So we would like to see more harmonious relationship at that level, and it becomes easier for us as ophthalmologists to be able to work with them. So in conclusion, the practice in Nigeria is a mystery where you have some people having good practices and good protocol in place. But there's need to practice under a standard protocol for everybody. It makes a paper review and comparison better. There's also need to harmonize, the laboratory and clinical practice. There's need to improve on clinical skills, appropriate documentation with diagrams and imaging. It is so that this webinar will set the stage for us to achieve this. Thank you so much for your attention. So that is where we've come to the end of that presentation. And I think with this, we've set the stage for at this point, we've set the stage for our resource persons to start talking. And I think the first person that will be talking is Dr. Aravind.
Hello and good afternoon to all. I hope my slides are visible and I'm audible to everyone.
Sure.
Thank you, Dr. Aribaba, for a very kind introduction. And thank you, Dr. Ogundepe, for the opportunity to share our experience with our colleagues from Nigeria. So, in our discussion here, we shall be focusing on the clinical features and evaluation of microbial keratitis, which is often a clinical conundrum, and try to understand how we can decode it, how we can approach it in a simple manner when we have a resource limited setting, and what can be done to enhance our diagnosis, enhance documentation, and enhance early referral.
Ivan, you are not audible, please.
Unmute yourself.
Yes, I am unmuted. Are you able to hear me?
Yes, go ahead.
If you look at the reported incidence of microbial keratitis from Southeast Asia, they are in thousands as shown on the screen. And if we compare it to the reported incidence in the developed nations such as in the United States, our numbers are much higher. A study from South India estimated projections of 840,000 new cases of corneal ulcers that occur every year in India. If we look at corneal ulcers, they may present with different and varied presentations and clinical patterns. Apart from the common symptoms of irritation, pain, redness, or some non-specific fall of foreign body, often there are subtle clinical signs, typical history, which helps us decipher what could be the possible etiologic agent that might be responsible for the microbial keratitis. Take, for example, this middle-aged farmer who presented with a 2-week history of trauma with vegetative matter. If we look at the ulcer, it appears to have a ring infiltrate. There are areas of full thickness corneal infiltrate. There are areas of melting and thinning. This could be possibly a bacterial, or more commonly probably in our setting, that of a fungal keratitis. Leading questions such as these help us elucidate or narrow down our search of the possible inciting etiologic agent in such cases. This was a young female who presented with a 1-week history of watering, pain, and decrease of vision in her left eye. We noted that there was a wet appearing ulcer, and if we can see at the temporal edge, there is almost a 90% thinning of the corneal stroma. There is a hypopyon that is filling half of the anterior chamber. This is a very aggressive microbial keratitis. This is caused by an organism which is very aggressive, and perhaps if left untreated will lead to perforation of the cornea and ultimately have sight-threatening consequences. This was a patient who had occasional history of decrease in vision. If we see, there are some faint corneal stromal edema, there are deep infiltrates in the central cornea, and trace hypopyon. These are suggestive of possibly an indolent organism, or perhaps it could be a viral etiology as well, where there are episodes of waxing and waning. This patient presented with severe pain in the eye following fall of muddy water. There was a patchy stromal infiltrate, and the infiltrate was localized to the anterior corneal stroma. These are features which should alert the physician about a possible acanthamoeba keratitis. Though there are several types of organisms which will have similar clinical features, but one should ask leading questions. And in this patient also, there was infiltrate around the peripheral corneal nerves as shown by the white arrows, which were indicative of a radial keratoneuritis. So a patchy stromal infiltrate with radial keratoneuritis again increases the suspicion that are we dealing with acanthamoeba. This was a patient who presented 1 week after uneventful clear corneal phaco with features of endophthalmitis and involvement of the clear corneal wound. These are suggestive of an organism which is perhaps a commensal, which is perhaps a part of the patient's own microflora. So possibly this could be a gram-positive organism. Why eliciting this information is important? Because this will help narrow down our search. This will help in providing adequate information to the microbiologist so that he or she can narrow down their search and look for the possible incriminating organisms. Sometimes patient present with a plaque which has a florid pigmentation on top of it. These are very typical of Demacious fungus. Fungal ulcers are very common. They constitute about 40 to 50% of all the microbial keratitis that we see in our practice. Finding a plaque on top of the corneal lesion is almost pathognomic of a Demacious fungus. And a new entity that has found renewed interest and resurgence is Pythium insidiosa. It typically has a tentacle dot-like infiltrates. There is a raised plaque that may be guttering in the periphery. These are features which should alert the physician that could there be possibly pythiosis here of the cornea. So when we take the history, it's important to elicit a history of trauma or an injury with vegetative matter. Was there any unsolicited corticosteroid use? Because this may have devastating outcomes in terms of the presentation being blunted because the features of inflammation are completely altered when corticosteroids are used. It may accelerate the melt of the cornea, and in case of a fungal ulcer, it may exacerbate the findings. Was there a arbitrary use of medications? Was there polypharmacy? Was over-the-counter medications used? Was there a poor ocular surface? Is the patient immunocompromised? Is the patient an uncontrolled diabetic, because that could be the reason for a non-resolving microbial keratitis? Are the lacrimal passages patent? Is there a history of contact lens use? These are some of the important questions that one should ask a patient of microbial keratitis. Our experience has been drawn from our publication in 2009 on the review of microbial keratitis, our experience of a decade, where we analyzed close to 6,000 isolates from patients of microbial keratitis. The number one cause of predisposing factors was trauma in almost all forms of microbial keratitis. 48.4% of patients had appropriate antimicrobial therapy prior to presentation, whereas 41.3% had an indiscriminate and non-specific combination therapy. Steroids were used in 10% of patients. As was mentioned by Dr. Bade in the previous talk, documentation is very important, not only for sketching out the natural course of the ulcer, but also as a useful teaching tool. The very simple way of sketching the corneal ulcer is from this article by Waring et al. And the normal color codings that one uses are orange for infiltrate and hypopion, green for fluorescein, lens and vitreous, blood by red, iris pigments brown, any areas of corneal edema with blue, and scar, degeneration, sutures and contact lens by black. I will briefly touch upon confocal microscopy. Usually this will be limited to a research setting or in a tertiary center, but where available, this is a good way to in vivo image the human cornea. The anterior stroma has elongated and activated endothelium background. The nerve plexus may be present in the subepithelial or subbasal region, which may be above or below the Bowman's layer. Stromal nerves typically penetrate the anterior to mid stroma, and they have Y or V-shaped bifurcations. They are thicker, 10 to 15 micron diameter. These are representative images of confocal photographs of a patient with fungal keratitis. Typically, fungal filaments appear as high reflective double wall septate filaments of 3 to 8 microns. They have a uniform width and they may have irregular branching. Bacteria are not visualized, but patients with bacterial keratitis have activated keratocytes with infiltration of leukocytes and Langerhans cells. And activated ovoid dendritic cells at the subepithelial layer is seen in the setting of viral keratitis. These are often overlooked on the slit lamp. Acanthamoeba cysts typically present as highly reflective double wall round particles of 10 to 20 microns diameter. They may be present either in the deeper corneal epithelium or in the corneal stroma. The inner wall has a hexagonal configuration. We published our experience of confocal microscopy in the diagnosis of fungal and acanthamoeba keratitis. When compared to culture positivity, which was considered as the gold standard, the sensitivity and specificity of this technique was 88.3 and 91.1 with a good inter-observer agreement. Another useful technique of collecting specimens from deep corneal stroma is the corneal biopsy. It needs very simple instruments. Whatever one has in the cataract set is usually enough. The lesions are typically in the mid to deep stroma, so the superficial flap is lifted and scraping are done. Then a small amount of tissue is harvested for microbiology and histopathology examination. This was a suspected fungal keratitis. After taking the specimen, the superficial flap is sutured with interrupted 10-0 nylon sutures. So when the harvested material is subjected to histopathology and to microbiology, the Gomori methanomin silver stain shows cut end of fungal filaments, and the gram stain showed septate filamentous fungi, and antifungal treatment could be initiated in this patient. Fungal keratitis is very common in our setup, and often they have very typical features such as a dry appearing slough, a slough which has a very irregular texture, ill-defined margins, satellite lesions, ring infiltrates, hypopyon, fibrin, and a very typical color of the infiltrates. So the question was that in the setting of a fungal keratitis, can there be prognosticating factors or predicting factors from the ulcer itself which can tell us that we are dealing with a fungal etiology here? This was the question that was addressed by Thomas et al. They ascribed serrated margin, raised dry appearing slough, satellite lesions, and color of the infiltrate to have a high positive predictive value for predicting from clinical signs that we are perhaps dealing with filamentous fungi. However, there is a note of caution. This is true in regions of the world where fungal keratitis is common. This could be in Southeast Asia, Africa. It could be in the southern United States, but this may not hold true in temperate climates such as in the United Kingdom. All in all, when one has a resource limited setting, then a very simple test that can be performed in the clinic is a light microscopic examination of corneal scraping with a 10% KOH wet mount. This helps to rule in fungi and acanthamoeba. We tested this hypothesis in a publication from our group where in the setting of a community eye center where microbiology services are not readily available, ophthalmologists are trained to perform a 10% KOH wet mount. We noted that there was an overwhelming percentage, 86.4% of patients who had fungal keratitis and they healed after early diagnosis and timely and appropriate treatment with antifungal agents. And we further estimated that 43% of patients would not have healed if we had not timely seen and diagnosed the patients to be of fungal keratitis. Therefore, something which is as simple as a 10% KOH wet mount, which basically consists of placing a bit of tissue in the slide, placing 1 drop of 10% KOH solution, putting a cover slip and examining for filaments is enough to help somebody guide the treatment towards whether it is a bacterial or a non-bacterial keratitis. And this was what was also recommended by the empowered group from WHO, which included both Aravind Eye Hospital as well as L.V. Prasad Eye Institute as some of the collaborating partners in generating guidelines for management of corneal ulcers in a primary, secondary or tertiary setting. This document is available free to download on the internet. Preparing the 10% KOH wet mount is also very simple. Most chemists would have pellets of KOH. So dissolve 8 pellets in 10 ml of distilled water, add glycerol, prepare a fresh stock, keep for use for every week and replace it. The management of corneal ulcers is often challenging in resource limited setting. One needs to understand the rationale of management, the guidelines for early referral and treatment. If somebody is dealing with an ulcer in a one-eyed patient or in a pediatric setting, or when there is a need for a surgical intervention because there is an impending or actual perforation, one needs to immediately refer. If not, attempt to treat, and to know that one should understand what is the etiological diagnosis, what could be the possible organism that might be causing it. Needless to say, and as we have discussed, the history can elicit different points of interest. And when it is supplemented with a good examination, with the emphasis on the size and nature of the infiltrate, the rate at which the ulcer progresses, the depth, the edges, thinning, and how the surrounding cornea looks like, that gives several pointers towards what could be the possible underlying cause. We attempted to address some of these questions in a recent book chapter that was published in Infections of the Cornea and Conjunctiva in Springer. So when we look at corneal ulcers, are we dealing with a rapidly progressive disease with suppurative infiltrate, or are we dealing with a slowly progressive disease with localized infiltrate? If we are dealing with a rapidly progressive disease, perhaps it is a very aggressive organism, which could be either gram-positive or gram-negative organisms. The gram-positives could be Staph aureus, Pneumococcus, Neisseria, or Pseudomonas, or it could be possibly a mixed infection. The features of Staph aureus infection is a marked suppuration, deep stromal abscess, endothelial plaques, and large hypopia. Pneumococcus have a focal suppurative stromal infiltrate. They have a serpiginous leading edge. There is cellular infiltration into the deeper stroma, radiating folds in the descemet membrane and retrocorneal fibrin deposits. When we are looking at a slowly progressive disease, perhaps we are dealing with fungus or protozoa, or we are looking at an organism which is not very aggressive. It could be Actinomycetalis, Moraxella, Staph epidermidis, or alpha hemolytic streptococcus, which is not pneumococcus. Gram-positive cocci usually have full thickness corneal infiltrate, well-defined margins, and they respond well to broad spectrum antibiotics. Gram-negative bacteria may have a lot of corneal melt and often rapidly progressive. There is a severe conjunctival reaction, dense suppuration, and a ground glass appearance of the surrounding cornea. Moraxella and Neisseria can have an indolent or a rapidly paced infiltrate. Moraxella has a superficial focal infiltrate and often may have some mild to moderate anterior chamber reaction. Neisseria is much more faster in its progression. It has conjunctival hyperemia and chemosis with thick, copious, purulent discharge, dense suppurative stromal infiltrate with preauricular lymphadenopathy. Nocardia is characterized by a wreath-like pattern due to calcareous deposits on the base of the ulcer. Usually, atypical mycobacteria may have history of injury with a metallic foreign body or a prior corneal surgery. It has a waxing and waning course. It has a very slow progression and non-response to most conventional antibiotics. So these are some of the very typical features that might be associated with different forms. Fungi may have plaques, pigments, satellites. There may be ring infiltrates with superficial patchy stromal infiltrates, which are characteristic of acanthamoeba. In our setting, the history of a contact lens use is not very important in the setting of acanthamoeba keratitis. What is important is rather exposure to muddy water. Often there is a history of injury with a cow's tail or buffalo's tail. And there is a patchy stromal infiltrate, and very rarely in 5 to 8% of cases there might be radial keratoneuritis where there is a perineural infiltration of the peripheral corneal stroma. These are pointers that perhaps we are looking at acanthamoeba. So what is the role of microbiology? Is it not important because we can diagnose all of this on the basis of clinical science alone? That's not really the case, because often patient may present with varied severity. There might be very overlapping signs. Often there could have been prior treatment with multiple drugs and that would have completely changed the clinical picture. Therefore, ophthalmologists are urged to send in scrapes for microbiology examination where facilities exist. However, in spite of very clear-cut presentation, in 30 to 50% of cases, patients have a negative microbiology, and it's not really clear what could be the underlying cause for the microbial keratitis. So what should we do? How should we treat? Should we only give empirical, or should we focus on a microbiology-based treatment? So when microbiology services are not immediately available, assess that whether we are dealing with a non-severe ulcer and it is unlikely to be fungus or parasitic. Even if it is smear negative, start with an empirical broad spectrum antibiotic. This could be a combination of fluoroquinolones with third generation cephalosporins or with aminoglycosides. If it's a non-severe ulcer which is likely to be fungal and it is smear positive, treat with antifungals. However, one should try to refer all cases which appear to be fungal but they are smear negative, because this could be anything, and these are best managed with a cornea service, with an appropriate microbiology service. So in summary, it's important to understand the science of managing the corneal ulcers, the art of making an etiological diagnosis, and refer to established WHO guidelines whenever referral is required. I would like to thank my colleagues, Dr. Prashant Garg and Dr. Praveen Krishna, for some of the material that was used for these slides. I would like to thank all the colleagues and thank all of you for a patient hearing. Thank you very much for this opportunity.
Thank you very much, Dr. Arvind. I think we should be noting our questions in the question and or in the chat box or question and answer box, so that at the appropriate time we can be attending to these questions and queries. Because we have spent some time at the beginning, we may have to move on now to the next speaker. That's Dr. Bhupesh. Dr. Bhupesh is a very close friend of mine. We were batchmates during our training, so we've known each other since 2006. And I still consult him when I have issues, and he's been very helpful. So, Bhupesh, I don't know if you have been granted the status of a co-host so that you can share your slides.
Yeah.
Yeah, okay, go ahead, please.
Yeah. Able to see my slides?
Yes, and we can hear you.
Yeah.
That's LB Prasad you are showing us.
Thank you, Dr. Bade, and thanks all for so I'm discussing, Arvind has covered most of the things which I was thinking to say, so I have very little to say in my talk now, but I will try to explain few of the things which I feel is important for areas where the poor setup. I think some mics are still unmute. Okay, so if you think about management of microbial keratitis, it has primarily contained important parts that relate to correct diagnosis, medical management, as well as physical management. With diagnosis, if you think in line of microbial keratitis, the immediately, I always think that these are the most important thing to make a correct diagnosis. But we are dealing some mics are on. I think a lot of hello. Am I audible?
You are audible, but apparently some mics are on this.
Okay. I thought I am disconnected. Okay.
Can we please try and mute our microphone so that the resource person can talk to us and is audible to us, please? check if your microphone is not muted, and kindly mute. Thanks.
Okay. So if you thinking about making a diagnosis of microbial keratitis, so these are the few pictures which comes in our mind, that to see under microscope and to see cultures and to diagnose by making microbiological and based on microbiological diagnosis. But as previous speakers, I saw that, and others, that we have some microbiological facility in Nigeria and other areas where we are talking about. And basically, we can develop those areas where the microbiology is not up to date. But if you see those, most of the things are not very high standard, except few machines like Vitek and all. But you basically need few, as Arvind pointed out, that KOH, calcophor white, or KOH plain, along with the gram staining, which are very easy to do and pick up most of the diagnosis. You can pick up diagnosis based upon that. Basically, you don't need that much species identification to treat many of the keratitis. But I am talking about few cases where you actually can make diagnosis to a quite precision with the help of your clinical acumen as well as with the help of your smears. So you don't need of species identification. So this patient is of 25-year-old, presented to us with a history of 2 and 2.5 months old, and using mixed therapy, cocktail of therapy, as previously pointed out, like natamycin, gatifloxacin, acyclovir, the history of 2 months. So when I saw this patient, actually it was having heaped edges with 360-degree deep vessels, and on smear there was no organism. So immediately I could track out that this is basically a sort of toxic keratitis where epithelial defect is non-healing, and immediately I stopped all the medications, and thus resolved within 3 to 4 weeks along with torsorrhaphy. So the importance of showing this in the beginning of my talk is that microbiology is sometimes negative and is not required. Basically, as clinical acumen that you think about, there are a lot of conjunctival congestion, a lot of deep vessels, heaped edges, and patients using those medications, those history actually can pinpoint and rule out most important diagnosis. Similarly, like this patient was having inferior heaped up edges of epithelial defect. The surrounding cornea is relatively acellular. You don't need to actually perform microbial workup in this. Only torsorrhaphy or bandage contact lens or a bandage or amniotic membrane actually can help. So this is a sterile persistent epithelial defect. So what all to see when you are seeing an ulcer? So basically you need to see area of involvement, size of epithelial defect, monitor it, size of cornea infiltrate, depth of involvement, anterior chamber involvement, limbus sclera involvement. So these are the basic examination point where you are heading to make a clinical diagnosis, and then you go for targeted microbiological diagnosis. So examine conjunctiva, like here you can see the conjunctiva is taking Rosberg stain and gives a picture that patient is having severe dry eye. Look at the lid margins, look at the contour of lid, lashes, corneal sensations of both eyes. It is unilateral, bilateral, lag of thalamus, tears volume, meibomian gland status. This actually ease out your making a diagnosis. So don't jump immediately to go for microbiological diagnosis, but see all this diagnosis. So basically, if you make it, then medical management is pretty simple. It's based upon the clinical feature, and then you classify your ulcer either in a mild, moderate, or severe when you're sure that you're dealing with a microbial keratitis, ruling out all the possible etiological diagnosis which I pointed out. So bacterial keratitis to come with, basically, as pointed out before by Arvind and Bade, they are acute onset, shorter duration, wet yellowish infiltrate with increased conjunctival signs, chemosis, congestion, discharge. You'll get a pinpoint history that 1 day, 2 days history, and surrounding cornea and tear chambers are more inflamed as compared to fungal keratitis. But these are not always true, but yes, these will give some clinical value. After confirmation by smears and growth, you can change then you can start the antibiotics. I'm sorry, this, yeah. So like this picture, if you see that is a central thinning with a history of 3.5 days. The surrounding cornea is cellular with hypopion, with increased cellularity, with central thinning almost near descemet thinning. You tend to make a diagnosis of bacterial keratitis and particularly Pseudomonas type of keratitis. Like this is a history of 1 day with the using of contact lens. You can't miss this. A lot of cellularity in the corneal stroma, surrounding corneal stroma with hypopion, with a lot of conjunctival congestion and chemosis, and the surrounding cornea is completely cellular. You can't even make out any point of cornea where the cells are not there. So these are the signs where you can pinpoint that this is look like that with Pseudomonas, and you need to follow this patient every hour. Basically in hours it can perforate. Like this patient responded to medical and as well as glue BCL to a relatively nice cornea with central thinning. With contact lens, she was improving. Like this is a Streptococcus pneumoniae. You can say, if you, I don't tell the diagnosis of Streptococcus, you see the ulcer is like a serpiginous. One area is growing like this, if you can see my mouse, and one area is having necrosis. So that's how Streptococcus pneumoniae behaves. It is very unlikely to be like Pseudomonas, where you see the necrosis and the surrounding cornea is so cellular. So basically we start after smears confirmation. If there are some organisms like GPC or GNB is coming, then also a combination of antibiotics. Particularly we prefer to use fortified medications like cefazolin or vancomycin if available, along with quinolones or ciprofloxacin combination. But we confirm after that the sensitivity or susceptibility base, we can change to monotherapy. You can argue with monotherapy with quinolones also can work. Yes, 4 generations quinolones like levofloxacin 1.5%, moxifloxacin 0.5% can be available, can be used if you are not very used for fortified medications, or if it is a cumbersome to use them, particularly in cases of mild to moderately severe ulcers. But yes, need to follow regularly to see the response. These I'm talking about when don't have susceptibility, because many of these ulcers respond nicely with this monotherapy as well. Coming to the other aspect, which is more common in our scenario, is fungal keratitis. So you have relatively longer history. This is I'm telling about the most common. You can have 2 days history, even if the fungal keratitis of the history of trauma is there. You have whitish, dry infiltrate, feathery extensions, you'll have satellite lesions, and very critical is when you scrape this ulcer, these are having a gritty sensations on corneal scraping, and any sort of pigmentation is there in the ulcer, it supports fungus. So like this, I was talking about the feathery. Excuse me. Okay, so these are like plaque-like lesion, very dry looking, having hypopion along with feathery extensions. So you can pinpoint like this is classical presentation of fungal keratitis. But there are varied presentations of fungus. It can present like a plaque-like infiltrate with feathery extensions along with clear cornea surrounding with hypopion. It can present like a pigmented plaque, as a ring ulcer, as a deeper pigmented mass, as you can say, pinpoint headed like lesions, a plaque-like lesions, a deep stromal lesions with plenty of vessels, with only a surrounding anterior stromal plaque with surrounding edema, and like only endoexudates. So you need microbiological support to confirm your diagnosis in many of these ulcers. But if you have most of the conditions, that can be picked up by clinical examination. But yes, seeing all these scenarios, you need microbiological scraping either anterior or from posterior to confirm your diagnosis. So based upon the filaments on KOH or calcophyll white, we confirm the diagnosis, and treatment is you start topical natamycin 5% alone, or you can add oral azoles in cases with moderate involvement, mid to posterior stromal involvement where the ulcer size is more than 5 or to 6 millimeter, or along with hypopyon. Few ulcers don't respond to topical medications, though are deeper. So we can go for intrastromal or intracameral injections. So indications particularly for these interventions are deep stromal infections like worsening of topical medication, extension to anterior chamber, extensive endoexudates. We preferably go for voriconazole or amphotericin B in intrastromal or intracameral route. So this is a short video of using intrastromal. You can see the exudates are primarily on the posterior stroma or on the endothelium. You can use a 29 gauge needle or a bent needle. I bent usually, and go till the mid stroma, need not to go till the posterior stroma. And as you hydrate your cataract wound after finishing your cataract surgery, similarly you need to inject or sort of barrage entire exudate. So you will see a stromal clouding around that infiltrate, and that's the end point of giving injection. Coming to mixed infection, like this patient of fungal keratitis, as I said, dry looking plaque, was responding nicely, but after 7 or 8 days of showing response, they started showing worsening. And on scraping, it came out to be a pseudomonas. So basically, if your ulcer is responding nicely, but suddenly got worsening on medical therapy, think about either secondary infections or posterior extension of that fungus. Try to rule out by doing corneal scraping again and adding accordingly your antibiotics. Like this patient of fungal keratitis on microbial on antifungus was not responding. Like this is after 4 days of starting antifungals. So we were doubtful that what is happening, but it came out to be a Staphylococcus aureus combination which grew later on. So when it's not responding, I skip this therapeutic PK video. Maybe I can present in the end. So pythium, as Arvind already pointed out, so difference between the pythium and fungus are basically clinical also. In fungus, I have showed you. In pythium, you see a raised plaque with surrounding fine tentacles. And in microbiologically, they are having little bit of dissimilarity that in fungus, you see septate. Dr. Savita Sharma will cover in her talk, but I will just touch it that in pythium, this is a broad aseptate filaments. So classical pythium keratitis features are tentacles with plaque, very fine tentacles with a guttering around the infiltrate, as you can see here. So this is a patient of pythium keratitis, which we treat with a topical linezolid along with the azithromycin eye ointment along with oral azithromycin. Topical linezolid is commercially available as an IV injection, need not to dilute it. You can straight away use 0.2% linezolid without dilution. And this need to be preserved in dark bottles. You can, if you can make a diagnosis by either clinical as well as by confirmation by smears as well as formation of zoospores. Dr. Savita Sharma will explain that technique if in her talk. That is actually a pinpoint of making a diagnosis of pythium. Acanthamoeba keratitis, which is another very important topic. Most likely you have history of use of contact lens, particularly in Western countries. We do also see this type of contact lens induced acanthamoeba keratitis, but most important cause is the trauma, and most important way of presentation is the ring-shaped infiltrate, which is seen in almost 60 to 63% cases. But important thing is stromal haze. Some sort of ring with stromal haze is characteristic of ring-shaped infiltrate. You can see radial keratoneuritis, as you can see in this patient, or classical of ring, as you can see in this patient. But see the surrounding cornea stroma and versus stroma in this and the ring, you can see a classical stromal haze. So medical management is biguanides, either in combination or monotherapy, but we prefer to use combination of chlorhexidine as well as PHMB. You can make it 0.02% to 0.06%. Either you can use azoles as well, and we have seen effect of newer drugs, oral oral miltefosine, which is recently FDA approved for the use of acanthamoeba keratitis for refractory acanthamoeba. There are a lot of controversy about the effect of steroids, but yes, there's a definite role of steroid in outcome of acanthamoeba keratitis, but need to use only if you have already used more than 2 weeks of anti-acanthamoeba medications, particularly indolent ulcers, where the inflammation is definitely more, along with persistent inflammation, scleritis, and limbitis. But make sure your ulcer size is actually should decrease with the medication, then only start with the steroids under regular close follow-up. Like this patient of acanthamoeba keratitis, almost 2 months of using steroids and combination of mixed therapy and antivirals presented to us, and on confirm as a double-walled structure ring here on the gram stain as well as on the KOH, calcium responded nicely with the use of combination of PHMB and chlorhexidine. Few ulcers are really very bad and almost limbus to limbus involvement along with scleritis, where we tried medical therapy, but sometimes it didn't work. We can still perform keratoplasty, either lamellar or penetrating keratoplasty. So this is the outcome after DELK in this particular patient. Coming to the next parasite, or you can say now it's in fungus in microsporidial keratitis, where you see multifocal coarse elevated punctate epithelial lesions, which can be easily make a diagnosis of adenoviral keratoconjunctivitis or keratitis. But if you see this type of stuck-on lesions, you can't miss it. And these are the lesions which are can be make a differentials of adenoviral keratitis. If you make a slit, you can see a raised lesions and multiple stick-on appearance on the corneal epithelium. While in cases of adenoviral, you see subepithelial lesions. You can see in the OCT, you can make a diagram, or you can make a picture here that this microsporidial keratitis are basically raised lesions versus adenoviral keratitis are subepithelial lesions. So you can easily make a diagnosis with the help of 10% KOH and calcium, along with you can pick this up in the gram stain also. So treatment is basically a debridement along with lubricants. And these are the self-treated, self-regulatory disease. You can need to basically debride it. No need to use of medications in this particular disease. Superficial keratoconjunctivitis can be managed by debridement or lubricants. Sometimes alone lubricants help without debridement as well. So this is the case of stromal lesion, where your patient was history of more than 8 months and being treated of antivirals. So you can see a stromal haze. We're not able to see here. Few KPs are also there. So using of steroids and acivir and acyclovir, but patient is not responding to that. So second important differential is macrosporidial stromal keratitis. There again, the importance of microbiology is there. So we make a biopsy and confirm the diagnosis of macrosporidial stromal keratitis. And on biopsy, we could track out the same macros and this thing. The treatment is at present is surgical, with few of the medications can work, voriconazole or fumazoline, with the limited outcome. But at present, the last day of therapy is therapeutic keratoplasty with decent outcome. Coming to the next organism, which is not very common and rare. So like this patient of microbial keratitis, almost treated with cocktail of antibiotics and antifungus. We have seen patients of more than 2 months of medical therapy also in this type of group. And you see the descimate force is like a cracked windshield appearance, along with hypopion, with chronically inflamed eye, but not much of ulcer size, but this is not responding. So this is a very rare, not very common acid-fast bacilli. You can see in 20% acid-fast, and this is the atypical mycobacteria which responds to you give amikacin, ivlosin, ciprofloxacin. This patient came out to Mycobacterium cheileni, And basically, we need to figure out that why this is not responding, some ulcers are not responding. Here, there's a definite role of microbiology lab. So this patient responded nicely with the help of Bactrim along with amikacin. Last few slides of my presentation is nocardia, as Arvind already covered. So this is a typical RITH, anterior stromal dot colonies, dot type of lesions are there, where you feel like a chalky appearance of the infiltrate. You scrape and you see a beaded filament in the AFB, and you can confirm it by microbiology alone. You can pick up by confocal also, and this is nicely respond to amikacin as well as quinolones. So many times as I saw the presentation of the last two speakers, they were saying I usually prefer to use it. We also advise always to use from the cornea, not from the conjunctiva strap. And this is not very difficult to do. And it's always advisable to take scraping directly from the cornea, from the ulcer edge and from the ulcer base. And if possible, inoculate all the possible medias as we are showing in this technique. So with this, I am ending my talk, and I can share these few surgical procedures with Dr. Bade, and if they want to share in their group. Thank you, Dr. Bade.
Thank you so much, Bhupesh. That was very, very stimulating, and I'm sure there are a lot of questions that will come thereafter. I hope we have the luxury of the time to attend to these questions. So I think we now have the Dr. Savitri to talk to us. I must again thank Dr. Savitri for the interest she's always had in making sure that anything that comes from me is attended to very well. I really appreciate you, ma, and I'm not taking you for granted at all. Dr. Savitri is one of the most celebrated ocular microbiologists in the world. I'm sure from the little of our profile that we've listened to, you will agree with me. And she's so humble and down to earth, and she will meet you on the corridor and be discussing cases with you, hoping that you will improve your practice. I don't know if she's been invited as a co-host so that she can share her screen.
Yes, she can share her screen.
Okay. Thank you, madam.
Okay, good afternoon, everybody. Can you hear me?
Yes, madam.
Yeah, good afternoon, ma'am.
I'm very appreciative of this particular conference online, which Bade has organized. Thank you so much for doing this. And I must appreciate the presentations which were made earlier, especially the questionnaire-based surveillance that you have done. That survey has brought out many things. Of which what is very important is that microbiology services are actually available in your area, and they only need to be utilized. And there is some hesitation in using, maybe because of cost or because of time, that the survey, I think, has given a lot of insight into that. And thank you, Bade, for doing this good job of conducting a survey. So I understand that facilities are available, and people only will have to be convinced that they need to use these services for the purpose of diagnosis and treatment of their cases. So here I am to tell you about the basic microbiology setup that may be available in your area, or you can make it available in your own in-house. I think there were 80% of people who said that in-house facility was available.
Yes.
So if the in-house facility is in the form of a general microbiology laboratory, which happens in a general hospital, that can be very easily modified, or they can be inspired to make some subtle changes to accommodate ocular samples. So am I correct in thinking that majority of those are general hospitals?
Your question again?
The hospitals which have microbiology set up, are they general hospitals or they are eye hospitals? Did you
They
get
are mainly general hospitals.
General hospitals.
Mainly general hospitals and teaching hospitals.
Yeah, I thought so. So the ophthalmologist actually should visit those general hospitals and try to motivate the microbiologists there to modify their systems or do some very small changes to accommodate the samples from the eye. Now let's see. We already know the types of eye infections we have, and we are dealing with the keratitis today mainly. And as has been told by the earlier speaker, there is a whole lot of different organisms that can be present, and we need to have systems to look for them. So looking for them, the first thing in my view is a direct observation of the sample under the microscope. Which has to come based on the clinical features. We can actually have a system for bacteria, fungus, and acanthamoeba as non-viral type of keratitis, and have a common system for that. And for viral, it will have to be different. And then this is followed by the isolation of the organism, that is in culture, and characterization of the organisms, that is identification. And if one can afford also to have the molecular evidence or PCR systems for identification of the organisms. This is just to show you that in a severe conjunctivitis with some corneal lesions, if purulent material is available, then one can just take a swab of this and make a gram stain, which is the simplest stain that anybody can learn. And one can find the presence of gram-negative cocci, which is nothing but Neisseria. It cannot be anything else other than Neisseria gonorrhoeae. So in this 17-year-old boy, this diagnosis was very easily made just by gram stain. So therefore, I call this as power of direct microscopy. You don't do anything. You take the sample, make a gram stain on the slide. By direct observation is what Dr. Bhupesh mentioned about microsporidia. That diagnosis is also made only by direct observation. The corneal scraping is placed on the glass slide, and you can stain with chalcofluor white or gram stain and easily find these organisms, and they cannot be cultured. We don't have culture for microsporidia, so we only depend on direct observation for diagnosis. Similarly, you heard both Aravind and Bhupesh mentioning about pythium keratitis. I'll be, or maybe in the discussion, we can talk a little more about this organism. The clinical features were described, which look similar to fungal, but the direct microscopy shows the organisms to be looking different than fungi. The fungi have septae, and they are more stout looking, whereas pythium has a very, very lopsided and aseptate broad filaments, which we can actually identify in the direct microscopy. So when you want to set up a minimum laboratory, if you go to a big hospital microbiology, you will find all these will be already available. But if you want to set up one, this is a list of items which can just be kept even in the clinic, just by the side of the slit lamp or in a corner. You can have these materials, and you should be able to do the minimal direct microscopy examinations for the diagnosis of some of your cases. Although there are publications which say that microbiology is not required when you have majority of your cases caused by bacteria, but this is not true for countries like ours and also Africa, where you have fungal keratitis, these red bars, are such a large number of patients have fungal keratitis. So we cannot be depending on what the Westerners say, that majority are bacterial. So why go for microbiological diagnosis? You can just treat with the antibiotics, but we need to differentiate our cases which are caused by fungus. And this is our setup in secondary centers. This was also mentioned in some way by Arvind, that all our secondary centers, which are small hospitals across 4 states in India, we have kept there a microscope with gram stain and facility for doing potassium hydroxide or KOH preparation. With these two alone, we have been able to diagnose a large number of cases, and Arvind did mention about the publication that Varsha Rati has made from there. Now this slide is to show you how useful KOH can be. The fungal filaments are seen slightly grayish in color, and you can also see Acanthamoeba cis. You can see even Microsporidia here. So with the keen observation, one can find many organisms. In contrast, you can find all types of organisms can be gram-stain, right from bacteria, fungus, Acanthamoeba, and Microsporidia, gram-negative, gram-positive, everything you can see.
For the next 5 years, Allah is a
Please, can you unmute yourself again? We're sorry.
I've muted him.
Let her unmute herself.
Madam, kindly unmute.
Am I audible now?
Yes, yes.
What happened in between? Somebody muted me.
Sorry, I have to unmute everybody. I have to unmute everyone because of the interference.
Okay, okay. All right. So what I was saying, that there can be overlapping clinical features, and here is one case which the clinician, a very experienced clinician, he thought it is 100% fungal. And he actually took the scraping and sent away the patient on natamycin, thinking or believing that it is definitely going to be fungal. And then he came to my laboratory because it was 6:30 in the evening. And he said, just tell me that there is fungal filaments in this. I've sent the patient away. And this is what we saw in KOH. These are the Acanthamoeba cis. We did not see any fungal filament, and it was full of Acanthamoeba. So clinical features can be overlapping and misleading even for experienced ophthalmologists. So Acanthamoeba, not necessarily it will have always ring infiltrate. It can look like fungal. And mind you, there is another case which we have published. This was a ring infiltrate. And I think many pictures Arvind also showed which were ring infiltrates, and they were said to be Acanthamoeba. But this is one case which we published, looked like Acanthamoeba, and again the clinician came to the laboratory saying that it will definitely be Acanthamoeba, but what we found was Staphylococcus species, not even aureus. And you can see the amount of growth, very heavy growth on blood agar from this corneal scrapings of this patient. We have many types of simple stains in the laboratory. Once you go to the laboratory, you will be told by the microbiologists there's so many types of stains are available. I have already mentioned to you KOH and chalcofluoride, plus also I mentioned to you gram stain. Now here is another stain which is called acid fast stain, and it is we using 1% acid. And the stain is also called quinine staining, and there was a mention of nocardia. Clinically, actually, nocardia is supposed to be very, very typical, but one can only confirm by seeing acid-fast filaments in the corneal scraping. Similarly, this was also mentioned, you can do using 20% acid-fast, the same gram stain, which might show unstained bacilli as is seen in this slide. And then you suspect that there is something which is not getting stained properly with gram stain. So we take the same slide, decolorize it, and then do the 20% acid fast stain, which gives the beautiful picture of these acid fast, very thin, beaded, curved bacilli, which are nothing but atypical mycobacteria. And the diagnosis is important because the treatment is very, very specific. Instead of giving any anti-bacterial like ciprofloxacin or other broad spectrum, you need to give 2.5% amikacin for the treatment of this condition. So here is a list of different type of incubation that is required for different media, blood agar, and I think the similar picture was shown by Bhupesh, that we take the scrapings at the side of the patient. Now, when you go to a general microbiology department, they may not be willing to send somebody to the ophthalmology clinic to take the samples. But I think you need to insist on that, and it's very important that the slides and culture media come to the clinic and you take the samples directly on the slit lamp. Without that, the results will not be good. I think later on we can discuss how exactly are you sending the samples to the microbiology laboratories. These are some other methods of other samples. They can be cut into pieces and put onto different media for culture. And what's very important to know is that the microbiology should be reporting what is significant. And we determine what is significant in culture by seeing a very large amount of growth on the sample which was put on the media, and if there is growth in more than one medium, or there should be consistency between what was seen in the smear and what has grown in culture. Antibiotic susceptibility testing we normally do for bacteria, and this is the most common one, this diffusion method. One can also do E-test, by which we can get the minimum inhibitory concentration of different drugs. Now, acanthamoeba does not form colonies. You look at the direct corneal scrapings and you find the cysts of acanthamoeba. And on culture, it is on non-nutrient agar, which needs to be kept under the microscope and then observed for growth of acanthamoeba. Identification, I will not go into details. It doesn't concern the ophthalmologist, but it's good for you to know how many methods are available and what your laboratory, which is available in your hospital, is using for identification of bacteria and fungi. We have molecular methods where we do PCR for, especially for vitreous. We do not do much for corneal scrapings because much of corneal scrapings and microbial keratitis can be diagnosed by the conventional methods. We do not really need PCR for that. And here is a list of types of fungi that we get in our cases. These are Fusarium aspergillus are the top ones, and you have Carularia, bipolaris, and some others which are black fungi also seen causing microbial keratitis. For identification of bacteria and fungi, we also do molecular methods of DNA-based sequencing, and that's become a common thing in our laboratory. So those which cannot be identified by the usual conventional methods, we'll go for sequencing. This is for viral. I think we did not discuss anything about viral, and probably most of you have not been really shown any technology. I don't know whether your laboratories will be having these methods available. What we do is mainly the antigen detection by immunofluorescence assay. You can see here the apple green, and this requires a fluorescence microscope. Similar to chalcofluoride also is a fluorescence stain. And this is the way the PCR result looks in a gel electrophoresis. And we do for many viruses, simplex virus, varicella zoster virus, and we do for cytomegalovirus very, very commonly, and mainly for the vitreous samples, and cornea scrapings we do for herpes simplex virus. So this slide is to show you that a very large setup is required for doing molecular methods, and it requires a lot of expertise, standardization, and validation while setting up this kind of a laboratory. Clinical correlation is most important when you do any molecular method, because it is a very, very sensitive method. You may detect organism DNA or RNA in many samples, but that should have a good clinical correlation to make sense and to proceed or take the results in cognizance for treatment. Now, what are the advantages of doing molecular methods? It rules out infective etiology because it is highly sensitive, and it is very highly specific as well. So it is a rapid and definite diagnosis of infective etiology. Reliable confirmation of unusual organisms. This technology gives and confirms the presence of organisms which are difficult to confirm, especially viruses and organisms which cannot be cultured. There can be some difficulties while doing this, and all laboratories who engage into molecular methods should be aware of the difficulties with that. But it's not true that we need molecular methods for all conditions. Here is an example which I have published saying that for acanthamoeba, the diagnosis using the smear or just the cornea scraping, gram stain, and KOH or chalcofluoride, which is shown in this bar, is almost similar to the results you get by PCR in terms of sensitivity, specificity, and predictive values. So I see no reason why we have to do PCR when the diagnosis by smear itself is to the tune of almost 80 to 90%. So in summary, ophthalmologists in dual role of microbiologist, basic microbiology in the clinic can be done. They can have a tie-up and one-to-one involvement with local microbiologists or their institutional microbiologists for culture and molecular tests. And orientation of the microbiologists in the general microbiology laboratory should be done in terms of sample collection. Actually, an ophthalmologist has to teach them. Familiarity with special direct microscopy features, sample processing, prolonged incubation. The general microbiologist usually will culture only for 24 to 48 hours, usually 48 hours. Whereas we, for ocular samples, we need 1 week. We need to at least incubate for 1 week. Quality assurance is important, and the laboratory, if it is accredited laboratory, it's much better. And incentivize a microbiologist in academic activities so that they will be motivated to do your work. So with this, I thank you for your patient hearing.